Hello everyone, and welcome to the third part of our Imaging for the Cardiac Surgeon lecture. This lecture will focus on aorta imaging. So the chest X-ray, although it is typically the first imaging that is obtained when the patient presents with chest pain, is not specific nor sensitive for the diagnosis of aortic dissection. Occasionally, it can show an internal displacement of intimal calcification that is created by the presence of a hematoma or of a false lumen containing blood in the case of an aortic dissection. Here you see side by side an example of a chest X-ray with the corresponding CTA image showing how the wall calcification are displaced internally. Although often considered among the potential imaging modalities for the aorta, I see that transesophageal echocardiography is more useful to study localized area of the aorta, especially the ascending aorta. This is an example of a localized aortic dissection in the aortic root. This is a 120 degrees view of the LV outflow tract and aortic root. You see the left atrium here, the left ventricle, the aortic valve, and a dilated aortic root measuring almost 47 millimeters with a localized dissection flap that is enough to create a significant aortic regurgitation. In this case, the aortic dissection was not seen on a non-gated CT scan, and TEE was required to make the diagnosis. A computed tomography angiography is the preferred exam for the imaging of an acute aortic syndrome. Acute aortic syndromes can be either an intramural hematoma, aortic dissection, or a penetrating aortic ulcer. In the case of an hematoma, you will see a hypodense collection relative to the true lumen that contains contrast. The difference between an hematoma and a dissection is that there is no intimal tear and there is a constant relation to the aortic wall. The most common presentation is an aortic dissection, where you will see typically a small true lumen and a larger false lumen with a beak sign, which is the acute angle of the false lumen that is absent in the true lumen. If you see an aortic dissection, always look for a pericardial effusion and for aortic regurgitation. And finally, a penetrating aortic ulcer can be at the origin of a hematoma, but you will see a discrete contrast-filled outpouching that corresponds to the ulcer. A CT scan is also very useful to image the postoperative thoracic aorta. It is important to always obtain first a non-contrast scan of the aorta. This will allow to identify post-surgical modifications that are hyperintense. Otherwise, you will not be able to differentiate the postoperative modifications from a contrast-filled cavity. This example, this is a non-contrast actually, this is an image with contrast, but the felt ring around the hyperintense contrast-filled lumen could appear as a circumferential dissection. However, if you have a pre-contrast image that already shows the enhancing or the hyperintense ring, then you know that it is postoperative change. These are other examples of postoperative complications. This is a collection around an aortic graft. The plaget here is hyperintense, and this is important to demonstrate that this is hyperintense before the administration of contrast, because if this was the only image you were allowed to look at, you could not be sure that this is not a contrast leak. A CT scan can also demonstrate other complications of open thoracic operation. This is a sternal osteomyelitis with a collection invading the sternum. There is bone destruction. And if you want to be sure that a collection is inflammatory, you can use a radiolabeled white blood cell scan, or in our practice, a PET scan. If there was a replacement only of the ascending aorta using a supracoronary graft, you have to remember that the aortic root is contains remaining native aortic tissue, and a localized dissection could occur in this location, which is not to be confused with a fold in the ascending aorta graft. In this case, there was a pseudoaneurysm arising from the proximal anastomosis of the graft with a secondary hematoma. Finally, if the patient has undergone coronary reimplantation, as is the case in a Bentall procedure, then you have to image the coronary buttons, for which coronary CTA is very good. Patients with connective tissue disorders such as Marfan syndrome are prone to developing aneurysms of the coronary artery buttons, or even pseudoaneurysm, as it is the case in this example. In summary, it's important to be able to discuss the plus and minuses of different imaging modalities for the aorta. You can start with the assumption that CT scan, except for the fact that it requires IV contrast, is a very good test. It is fast, it is available, it has little operator dependency, and it is safe for the patient. MRI provides additional information, for example, about LV size and function, but it takes longer, it is less available, and it's not as easy to reach the patient in the magnet if the patient develops instability. Transthoracic echocardiography only shows the proximal part of the aorta and the aortic root. Therefore, it is less efficient for the transverse aorta and the descending aorta. It also has sensitivity that is too low to rule out aortic dissection. TEE has many advantages, although because there is a possibility of hypertension at the insertion of the probe, it is really preferred either to look at a very localized segment of the aorta, or if a CT scan is absolutely contraindicated. You have to remember that the transesophageal echocardiography has a blind spot over the distal ascending aorta because of tracheal interposition. Finally, invasive aortograms are no longer used for diagnostic purposes. They are only used for interventional purposes. This is a summary of the consideration for non-invasive imaging of the thoracic aorta that we wrote a few years ago. I think it remains current, so if you want to pursue further the review of different guidelines and different techniques for imaging the aorta, I encourage you to read this review. I will conclude this series of 3 presentations about a few remarks about how to approach imaging studies. First, during your exam, what you should do is identify the modality, identify the view. Remember that CT scans are usually presented in standard perpendicular radiological planes, so axial, coronal, or sagittal, as opposed to echocardiograms or cardiac MRIs that are presented in cardiac-centered view, like the 2-chamber view or the 4-chamber view. Take time to identify all normal anatomical structures, and that should make anomalies stand out. For an exam, I think it is safe to expect that anomalies are likely to be severe or fairly obvious. In your practice, it's very important to collaborate with the imaging specialist at your institution to know what imaging expertise is available, and to make sure that your imaging specialists understand what you need to know to plan and to follow up for the procedures that you do. So I thank you very much for your attention, and feel free to reach out to me if you have any questions. Thank you very much for your attention.